It's International Sickle Cell Disease Day. Welcome to this webinar in partnership with Novartis called Sickle Cell Disease, a Healthcare Priority in the EU. Good afternoon, my name is Dwayne Schultes. I'm the Managing Director of Vital Transformation, and I'd like to thank you for your participation today. Many patients with sickle cell disease only live into their 40s, enduring unpredictable episodes of pain which disrupts their lives physically, socially, and emotionally. It's a lifelong, debilitating disease. Despite the World Health Organization recognizing the need to address sickle cell disease, there is no coordinated approach to tackling the disease at the European level. This genetic trait continues to spread across the world with increasing global migration. A lack of awareness among health policymakers and the public makes sickle cell disease has been nearly invisible. To help bring this chronic disease out from the shadows, we are joined today by a panel of EU experts in this one-hour webinar. And I'd like to introduce you to that panel. First, I'm going to start with Miriam Santos-Freire, who is a patient advocate from the UK. Good afternoon, Miriam. How are you?
Hello, I'm fine. Good afternoon.
Thank you for your participation. I'd also like to introduce you to Dr. Marianne de Montalembert, who is a practitioner from the EuroBloodNet. Dr. Montalembert, thank you very much.
Nice to be with you.
Thank you, Dr. Lambert. Just if I could ask you to move a little closer as you're presenting, that would be helpful. I'd also like to, thank you, perfect. I'd also like to introduce you to Yolanda Ajibi, who's the head of patient relations and sickle cell disease at Novartis. Yolanda, good afternoon.
Good afternoon, everybody. Thank you.
And finally, Simone Boselli, who's the public affairs director at Novartis. Simone, how are you, sir?
Thank you very much. I'm very well, Dwayne, and good afternoon, everyone.
Thank you. So I'd like to first begin by turning the floor over to Dr. Montalembert, who will be describing what is sickle cell disease, who is impacted, and its frequency. Dr. Montalembert, the floor is yours. Thank you.
Thank you. I would like first to thank very much all people for proposing me to see with you what is sickle cell disease. As you can see on this little cartoon, sickle cell disease is related to the sickling of red cells responsible for occlusion of small vessels, which limits distribution of oxygen to tissues. The sickling of red cells is related to the polymerization of the oxyhemoglobin S in the oxygenated condition, but it appears most recently that also white cells were involved, explaining that new therapies can be now proposed. Thank you. This, This disease is genetic, and therefore two parents, apparently asymptomatic, but having the sickle cell trait, have a 25% probability of having a child affected with sickle cell disease. In children, the disease is mostly related to polymerization of the oxyhemoglobin S, and you can see on the cartoons dactylitis, splenic sequestration, infection, and acute chest syndrome. But as they are going older, they still experience of infection and pain, but they experience also the consequences of the modification of the blood vessel wall, which we call endothelial dysfunction, and they can have pulmonary hypertension, chronic kidney disease, and strokes. And here is the picture of sickle cell disease in adults with, of course, the risk of pulmonary hypertension, cardiac involvement, brain disease, liver, hip, bone, and nephropathy, leg ulceration. This is a model. This is an estimation, a cohort emulation model, which compares data on a sickle cell disease cohort and a matched non-sickle cell disease cohort. And on the bottom, on the left, you can see the life expectancy, which is quite decreased in sickle cell disease patients. In this estimation, it was above 50 years, but it was 70 years in the cohort matched population and 79 in the general US population. And as well, the quality of life is decreased. The rate of morbidity and the mortality rate is well known by the patients who experience depression in about 35% of the cases associated with pain and lower quality of life. Sickle cell disease has become a health challenge in Europe. And here in this slide, you have data with data from newborn screening, which is experimented in many countries. And here are the most important number of births in England and in France. There are 40,000 patients affected with sickle cell disease. To improve access and quality of care for sickle cell patients, the European network, EuroBloodNet, has, in the respect of patients' rights and confidentiality, organized some actions. And here is RADIP, which is a rare anemia disorder in European epidemiological platform, which wants to increase the number of patients to share and pull data, reach critical numbers in order to perform clinical trials and lead research projects, to enhance knowledge, and finally to provide better healthcare for the patients. And here are some of the achievements which have already been applied. The cross-border collaboration agreement for the bone marrow transplant between some countries. We have seen the register. We are organizing preceptorships for health professionals, which are going to be in France overseas, Italy, UK, Spain, with EuroBloodNet sickle cell disease experts. There is a repository for educational documents, both for patients and health professionals, establishment of a network of patients and sickle cell disease advocates, a survey on patients' expectation, quality of life, educational needs, training session for patients such as videos also. And now has been implemented a register for the COVID-19 infections. And I would like to finish this short presentation with this list, which has been created at the past ASCAT meeting. And it was a forum which gathered expert patients from 12 countries, 30 people. And they were invited to list the top 10 questions that patients who are living with sickle cell disease would like the research community to focus on. The first was, how can we find a universally available cure for sickle cell disease patients? How can we improve quality of life? What are the implications for work and for education? How do we advise people, employers, and schools? How do we manage acute pain to prevent hospitalization? How does staff diversity or lack of diversity affect the way patients experience racism, discrimination, and stigma? How can we harness political agendas to improve care? How can we optimize pregnancy? What complementary therapies could work, including cannabis? How can we manage chronic pain? And what is the impact of a comprehensive care team on outcomes for people living with sickle cell disease? And I will be happy to answer your questions.
Thank you very much, Dr. Montalembert. If any of you would like to submit any questions on that presentation, please use your Q&A button. As I mentioned earlier, we'll be taking your questions and submitting them to the panel. While the questions are coming in, Miriam, a quick question for you. Can you describe your experience with sickle cell disease in the UK? How has it been managing?
Hello. So I am Portuguese, born in Angola, and I moved to the UK a little bit over 5 years ago. And it is a challenge having, I think, any chronic disease, but particularly SCD. And the main problem is that I faced was changing addresses. So I was living in another county initially, and then I changed to this one where I am, and it's almost like moving to another country. And now in the same town, I changed from one address to another one, and I was asked by my medical practice to change to a different one, which didn't help because the information doesn't move along with the patient at the same speed, and there's always something which is lost. So that was the first thing, is even if you agree to share your information with all the healthcare units, it doesn't work very well. And it doesn't work very well between the medical practice, where I go to the GP, and the hospital for hospital admissions, and the consultant specialties. And if you are followed, as I am, for cardiology in London and not in Cambridge, sharing the information doesn't work very well. So I tie the dots and I connect things via email. I keep copies of everything, but that is a challenge. Then the other thing is, if practitioners are aware of SCD, so in general and recently a lot more than when I was a child or a teenage, I can notice that. But the first thing is like a surprise element, because I am white, and typically SCD is considered a Black patient's disease. And so that is the first thing: do I really have SCD? But I am very well documented, and that helps quite a lot. Then in general, there is no plan or no 360-degree care. So as you get older, there are multiple areas that you have to monitor. And it is basically down to me to organize myself, keep notes of everything, have copies, discuss, and keep a control diary, and ask if there is something that I need to control more than the practitioner saying that you need to do this or that, or coordinating the specialties. So that's the other thing. Then one of the things that is becoming more and more common, because there is a lot of people, and here in the UK even more, is that I only get to talk to the secretary from the medical practitioner, or I have phone consultations and not direct consultations. So for example, I am with the new GP for a year now. I have never seen my practitioner. And I know that they are the lead practitioners, but when I call them is like on a need basis. So what's wrong with you today? What can we do to help you? Rather to have a plan and to have a follow-up in terms of yearly care. That is only happens usually with a hematologist. But if you go to specialist appointments for a specific issue, like gallbladder stones or thyroid or something, then you get really focused care, and they know more. If they don't know, they ask to someone who knows more. I know that here in Cambridge, I'm one of the very few SCD patients, but I know that the hematologist talks to others that know more and have more experience to provide the best care. And so that is very good as well. A good thing is that I have a good communication channel, and I also have it in Portugal. Fortunately, it doesn't happen everywhere, but I know that for me, it has been a case of being able to talk to the hematologist by email more than by phone, and or via an app. And that's very good to reduce anxiety, because many times a quick question and a quick answer guides you in the right direction. And that's it, because delayed care can lead to many complications and trigger a crisis, trigger going to hospital for emergency care and things like that. Then what else? No priority in booking appointments. So it's irrelevant if I say that I have a chronic disease and I really need, it's urgent. It's really irrelevant, and sometimes it is very tricky to get an appointment. And one thing that helps, I've learned it over time, is to always mention from the beginning that I have SCD, and I am aware of a lot of things with SCD in my case, and to try to say that I know what I'm talking about. So I'm not making up. It's not a delusion. That is a real problem, and I need some attention to know if it's something that needs some specific attention, or if there is a quick fix for it. Yep. And yeah, I think that's it.
Finally, thank you, Miriam. Just quickly, if you could just quickly respond to something. It sounds like when you change practitioners, you're almost teaching the doctors in some level. Do you find that there's a real difference in knowledge depending on where you are? And again, if you could just be brief on addressing this, how much variance is there between medical knowledge when you change practitioners?
Yes, I noticed that there is a lot. So and it's not just here in Portugal; it's the same, and it also, yeah, there is a lot of difference. Some
Sure.
know very well, some just know a little bit, and but it does help if you have some knowledge, because SCD is different from patient to patient. So you have some knowledge on what it is and how it is in your case, and you have like letters and exams and results to show that to the doctor. Yes.
Thank you, Miriam. I'd like to bring in Yolanda now. Yolanda, the industry obviously is leading a multi-stakeholder approach to engagement around sickle cell. Why is Novartis taking this on right now? Why do you think this is important, and why is it needed now?
Thank you, Dwayne. As you nicely introduced, despite the World Health Organization having stated a decade ago that more attention should be given to sickle cell disease as a global public health issue, we haven't seen yet any major actions to address the disease. And in Europe, the situation doesn't make exceptions. We have seen, for instance, across Europe, the lack of epidemiological data, the lack of systematic and comprehensive approach to address the disease, including newborn screening programs, and the discrepancies in healthcare access. And additionally, the non-audibility of the patient voice. So as you know, the COVID-19 pandemic has highlighted the vulnerability of the sickle cell disease patients. And additionally, the fragility of the specialized facility that used to manage those patients, and hence the healthcare inequalities the patients have to face. And I want to remind you, as Professor Marianne de Montel-Lambert stated, that this is a lifelong disease, and having access to healthcare facilities is not an option for the sickle cell disease patient. So as a pharma company, we have developed interest for sickle cell disease since 40 years. And though this has been the first monogenetic disorder for which the mechanism have been clearly identified, there has not been so much progress in the disease management. And worst, what we have seen is that the impact of the disease on the patient is not really well understood. As a recent global survey stated, so this global survey included 2,000 patients from all over the world, caregivers, and also healthcare professionals. This recent global survey gives us evidence that we were underestimating the disease burden on the patients. And amongst the findings, we found that 43% of the patients were treating VOC crisis at home because they had previously experienced poor experience in the hospital facilities. So at Novartis, we really believe that more needs to be done and can be done for the sickle cell disease patient. This is a reason why, as you mentioned, Dwayne, that we will be launching a multi-stakeholder coalition comprising of patients, healthcare professionals who are specialized in the disease, and all the stakeholders who are having interest in the disease, to better identify the needs and the challenges around the disease and to take actions.
Thank you very much, Yolanda. And again, we've had about 7 questions come in from the audience. Thank you very much. We will 8 questions now. Thank you. They're still coming in. We will be getting to those just in a couple minutes, I promise. We will take your questions. But first, I do want to go to Simone. Simone, obviously, you're Novartis leading the orphan drug and rare diseases groups in Europe. What action should the EU take now regarding emerging orphan diseases such as these that are really related to immigration? This is relatively a new disease from the European perspective. What does the EU need to do?
Well, thank you, Dwayne, and thank you everyone for shedding a light on such an important disorder. When listening to everyone, particularly Miriam, I cannot relate to many other diseases, rare diseases that we face. You know, the characteristics that you are highlighting are of similar to many other rare disorders. The difficulties in navigating the complex healthcare systems, the lack of specialized knowledge, the difficulties in accessing services. And in this case, though, they are exacerbated by both the novelty, perhaps in the European Union, but also for ethnicity reason, which is clearly identify the problem. But here, I think I want to give a message of real hope. And this probably what Dr. de Montalbert was highlighting in the first presentation, the role of the European reference network, particularly the activities of the EuroBloodNet in this case, collecting and connecting and structuring the collaboration between first the medical profession, but certainly the patients and the different research and industry are of primary importance for finding adequate care, which doesn't only mean treatment. By the look of things, sickle cell disease is the epitome of the typical situation for a rare disease patient. Our recent rare barometer survey on access to treatment and experience with treatment shows that above around 7,000 patients, only 5% of them have reported that they have a treatment that is truly transformative. And this is the case for the majority of treatment. But I would say that this is where we need to progress and move forward from the successes that we have had at European Union level. Fortunately, at European level, and for us in the rare disease community, we saw very early on the importance of collaboration and structured cooperation because of the lack of knowledge on how to manage the disease, lack of information on the disease itself, lack of registry and data to put forward a proper research into new treatments. COVID-19 has only pushed forward a notch and to the understanding of the entire population, the challenges that we face. And I think with the recent two combined pieces of work that the European Commission has put forward. One, the EU for Health program, so the public health funding program that has increased from 450 million to 9.5 billion euros, the money that should be invested in health in Europe, in brackets, it was long overdue, just between us. And secondly, the pharmaceutical strategy that is also been now put for consultation gives us an opportunity and gives us the sickle cell disease community the opportunity to highlight the specific problems and challenges that are forward, but indicate the willingness of the European institution to cooperate on issues that prior to that were not so much discussed upon, such as access, availability, affordability of treatments for what it matters, the pharmaceutical and medicines, and on the other hand, to invest properly and invest accordingly to the expectation into the European reference network in order to create the infrastructure that is necessary to truly have a European healthcare system that benefits the individual patient like Miriam by pooling the knowledge, pooling the understanding of how care should be given to people with sickle cell disease.
Thank you very much, Simone. Thank you very much. I am going to, again, we've got a lot of questions coming in, so I'm going to take just a couple here to begin. We have a comment here from an anonymous attendee. Again, thank you. They say, thank you for sharing your experience, Miriam. You take true control of your disease by connecting all the dots, and you make sure all the care specialists receive all the information. However, not all sickle cell disease patients are capable to do so. What is your advice in those cases?
Yeah, sorry. There a lot could be said about that. Yes, it is a fact. I am very organized by nature, and my profession has to do with quality, so that helps. But I have a very good memory, but I created like a spreadsheet where I make a note since I moved to the UK, because I have to, I have appointments here, I have appointments in Portugal, and I have to move everything from Portugal here, but still keep some connections there because I go there very frequently in case something happens. So the thing is that I created a spreadsheet where I make notes of all the contacts that are related to the different specialties, contacts with the GP, like the vaccinations, medication, and everything, so that I know exactly, because sometimes that information is important. And I had 2 surgeries since I arrived here in the UK. It was time to do it. And all that knowledge is very important. So I'm afraid there is no way that you have a central record of everything that happens with you. It would be very good, but it doesn't happen. So it must be on your initiative. I know that I think there is a French mobile app and there is an American mobile app as well that help the patients organize themselves in that sense, and have it in your phone is really helpful. Although it helps a lot, I am a bit suspicious because sometimes you don't have network or you lose your phone or something. So I organize myself in my computer and then I have a copy in my mobile or something like that. So it is really down to the patient, but I think that associations, and it has to be a joint effort with the doctors and the associations to train both the doctors and the patients on what is the important information that you should keep, and that you should really keep a record of it, because it will be necessary at some point, and especially as you grow older and more specialities come into play. So I don't have like a magic wand. It would be very nice. I just created a spreadsheet and started putting the date, the specialty, what happened. I prepare my appointments. I take notes from the appointments, and then I keep it synchronized with my diary to whatever may happen. And that really helps a lot.
Thank you. Dr. Montalembert, do you have a comment on that? What should patients do if they need to manage the disease? Obviously, you're an expert and you work in this field, but there aren't many of you out there. What should a patient do?
Well, in fact, in many countries, those reports are given by the doctor. And as in my clinics, we have, and in Paris, I think that Yolanda can also give this testimony. The patients, they receive a file of everything, and they have this sheet of paper is completely filled by the doctors. So it is helpful. It is really helpful, but really in many countries, it is organized and it is recorded on the computer of the institution. And so many patients are moving from one hospital to another hospital, and we have those information kept. So I think that there must be attempts from all the health system to systematize the system of keeping information, because in some centers it is done.
That's great. Thank you very much, Doctor. We have another question here. Yolanda, I'll just throw it to you. Just quickly, are there things in the research pipeline right now?
Yes, so there is hope for the patient. There are many companies investigating sickle cell disease, both from pharmaceutical side, but also cell and gene sides. And yes, there's new therapies coming. So this is the hope, and I really believe this is why now we have to address all the things that we do not know around sickle cell disease.
Sure. And then again, Dr. Montalembert, for you, does the Euro Blood Network have grants available for researchers who may be interested in working in sickle cell disease?
Well, I have begun to work with patients on sickle cell disease, I should say 30 years ago, and there were no drugs at all. There was penicillin and aciclovir, and that was all it was. But now there are hundreds of research, because as I showed you on the first slide, we have discovered that not only the red cell, but the white cell, the platelets, the blood vessel are involved. So there are hundreds of drugs which are in the pipelines. And the hydroxyurea has changed the life expectancy of many patients and the quality of life. And also there is a lot of research about cure, which is under the several options. There is the option of bone marrow transplant, there is the option of gene therapy, which won't be possible for any patients and which may be risky by some aspects. But for the research, I should say that life has completely changed. We have a lot of hopes.
That's great. Thank you very much, Doctor. Simone, I'd like to bring you into this question. Can you discuss sickle cell disease in the context of the need for equal treatment across all the member states? I mean, obviously the European union has a commitment to this. How are we doing with diseases such as sickle cell?
I don't want to take to any detriment to sickle cell disease. I think that there are two parts of this question. One is the need for equal treatment and equal accessibility between countries.
Sure.
Sorry, for rare disease patients between countries, at least in the European Union. It is, and we've been reminded by the COVID-19 pandemic of the role of Europe in health, and in the treaty. The European member states do commit to maintain a high quality level standard of health for their citizens. Well, they leave out the health system set up in that sense, but this is one priority they have committed to. The fact is that it is not always the same, and we see it, it differs from country to country and within country itself. For most of the over 6,000 rare diseases that have been identified, we have seen that there are pockets of rare diseases that have experienced research, that have experienced great a breakthrough in some areas, but this still represent a minority of the rare diseases, although some of those diseases were quite prevalent and therefore have looked at more people. But even when the treatment are available, they're not necessarily accessible in the country where they lived in. Yolanda and Dr. de Montalembert also raised the point around cell and gene therapies. With these new treatments, we will see them given out in few centers in Europe, let alone in the individual country. Thus, the possibility to move across borders to access adequate treatment increases, and this is still, we see it even recently, a problem, because the provision on cross-border healthcare vary very much in the interpretation of the member states. Now, and accessibility for minorities is it's been exacerbated in this sense. So from what we see from our evidence, we see that there are major differences between countries on the diseases across the different ERNs. We see that that this gap has not been filled in yet. And I think if we go back to the spirit of the regulation that you're quite familiar with, we are only asking to receive the same level of quality treatment as anyone else.
Thank you, Simone. Yolanda, I'd like to come to you. How do you think Europe needs to adapt to reduce health inequalities? What do you think needs to occur? Obviously, you're putting together a multi-stakeholder group in this condition. What do you think more broadly needs to occur, Yolanda?
I think the source of health inequality is the lack of awareness and the lack of understanding of certain disease, certain disorders such as sickle cell disease. So for me, the first action will be to better understand not only the pathophysiology, because this is already quite well understood for sickle cell disease, but also the disease burden and the impact of the disease on the patient life. And as I mentioned earlier, this is something which has not been addressed in sickle cell disease. The impact on the patients, both physically, but socially and emotionally, the impact on his relatives, and the impact as well on the healthcare system. And I believe that bringing more objective data to the let's say decision maker will support reducing these health challenges and health inequalities.
Thank you, Yolanda. Miriam, I do want to come to you quickly just for reflection here. What's been your experience when you've traveled around Europe? You said you've been in Portugal, you've been in the UK. Do you see equal treatment, or is it just catch as catch can?
That's a difficult one. So one of the things that I didn't experience in the UK, fortunately, is that I had no crisis that required hospital admission in emergency. So that's something that I don't know how it is in the UK. That was my main concern when I moved here. So I started taking care of everything. So first registering with the medical practice, and then making sure that I had a reference consultation at the hematologist specialist. And that was my number one question the first time I arrived at the hematologist. Okay, so in case there is an emergency, what do I have to do? Where do I go? What is the analgesia plan? And all those things. So that was really my main, and it took a while. It took like over 6 months, but it has been very stable. I also am very conscious and lead a very uh, calm life, if you want, trying not to poke the disease. And so that helps, but I don't know what it's like in that emergency situation. As for the rest, it really varies. So I was fortunate enough to always be around big cities. I think that helps. Now in Cambridge is one of the leading points of the world in terms of medical care. So even though they have few SCD patients, the knowledge in general is very good. Previously, I was around London, not specifically in London. And related to the question that you asked me earlier about the knowledge of practitioners, if it varies, I also think it has to do with the number of patients of a specific disease that there is in that area and that they have contact with. So
Sure.
that is really important. For example, the reference centers and the communication that Simone was talking about, because if they don't know, they need who is leading in that area and who to refer to and ask, okay, I have this case, what can I do in this situation? And that is really important. So I'm not sure if I'm missing something from your question, sorry.
No, that's great, Miriam. Thank you. No, we're just looking for your input on this because you deal with it more than any of us, with the exception of Dr. Montalembert. Now, Dr. Montalembert, I'd like to bring you in now. We have another slide here and some, like, your reflections about what are the implications to patients if treatment is missed or late when dealing with sickle cell disease. If you could please comment on this, and I'll bring up your slide now.
Yes, in fact, it is not a very easy slide because the implications are very severe if treatment is missed or late. And there may be acute complications, and most of the complications, as it was said by Miriam, is pain. And pain may be a nightmare, in fact. There may be sequelae of strokes. If you take care of a stroke at once, you may escape all sequelae, but if you wait, it won't work, and you will have sequelae. And if you have severe infections, acute chest syndrome, strokes, in fact, and if you do not take care of them, there is a vital risk which is engaged. And as chronic complications, if you do not screen for chronic complication, you may have motor or cognitive disabilities, chronic kidney disease, pulmonary hypertension. And as Yolanda says, there are consequences, depression, low quality of life, and finally, premature death.
Thank you very much, Doctor. We do have quite a few questions here, so I'm going to jump ahead here to take a few of these. We have one here related to COVID-19. The actual situation of COVID-19, does anyone know if patients with sickle cell disease are being adversely more affected than people in general? Doctor, I'll start with you. Are you aware of any comorbidity impact of COVID-19 with sickle cell disease? Have you seen any of that in your practice?
Well, in children, children were rather protected. They had few cases and few cases of acute chest syndrome. So it was not a question in children, but in adults, it could be a real problem for adults older than 40, 45 years of age. And interesting. It was also a problem more for SC patients. We had more problems in SC patients than in SS patients. In France, we have a register. We have in France, we said 30,000 people affected with sickle cell disease, and we had, the publication was 120 cases all over the territory, which is not a very high number. And out of them, there were 2 deaths.
Okay, thank you. I have a question here about diagnostics. Are there any companion diagnostics with newer therapies as there are for sickle cell disease? Yolanda, are you aware of any diagnostics or any companion diagnostics?
Companion diagnostic, no, but the diagnostic that I mentioned already is a newborn screening. So in Europe, you have the opportunity, thanks to the rare disease policies, and Simone can confirm that, to be screened for sickle cell disease. And in some countries, you have national-wide newborn screening. In some other, you have regional newborn screening program. And in some other, you do not have this newborn screening. And this is really a key, because the reason why this rare disease policy and measurement was implemented is to prevent at a very early stage the complication to occur. And Professor Marianne de Montalembert will be confirming, but if you do not manage at a very early age a patient with sickle cell disease, you can, there has been studies that have shown that the patient won't survive over 5 years old. So this is a general newborn screening which is performed, but doesn't exist everywhere in Europe, unfortunately.
Dr. Montalembert, do you want to comment on that?
Well, in fact, Yolanda, she's completely right. The more early you take care of the patients, the better life expectancy they have. What said Yolanda was applicable to Africa. The very shortened expectancy, life expectancy is true in Africa, because in France or in Europe or in Great Britain, in Belgium, when you have a severe infection, if infection will be treated, which is not the case in Africa. So it depends of the environment, the life expectancy, but sure, if you go early with treatment and management and also training of patients, you may hope really a good life, a better life.
Thank you. Simone, you wanted to come in with a comment, please. Thank you.
Yes, I wanted to refer to the patchwork that is newborn screening in Europe. I think that's, again, goes beyond sickle cell disease, but certainly in all cases that whereby an early diagnosis can reduce risk for the growth, it's worth doing. But we see, and we have now since last year started again working as Novartis and bringing together other stakeholders to see what we can do to harmonize in some ways the policies of newborn screenings, because you can go from the 40 up from Italy to the very low numbers that we have in France in terms of disease of the disease panels, and having the right balance. It is true that in many of the very rare diseases now we see some treatment in some emerging treatment, but that doesn't matter really. Knowing what well, it matters, sorry about that, but it is also equally important for the parents to understand if there is a disease, to plan, to understand, okay, now I know what's wrong or what could be wrong, I can prepare. And I think that's a much better proposition to have. Even though there might not be available treatment, there will be care pathways.
Thank you very much, Simone. Got a question here. I mentioned this at the top, but it's a valid question. Is there, up to today, any real cure of this disease? Is there any cure? Yolanda, I'll start with you. Is there a cure? You're muted, Yolanda. I'm sorry.
1 minute, apologies. So yeah, there is one cure, but which is not accessible to all the patients. This is bone marrow transplant. And again, Professor Marianne de Montalembert will confirm and will give more details. And there is hope towards new therapies, but I mean, the cure has not been confirmed through the gene therapy, cells therapies.
And Dr. Montalembert, the cure, how effective is the cure, the cell transplant?
The cure is effective. It is bone marrow transplant, and it cures the disease, really. But first, you need to have an HLA identical donor, which is not very frequently encountered We know that less than 1/5 of patients have a bone marrow donor, which means a brother or a sister with the same father, the same mother, and HLA identical, and then it is not totally without risk. Even if you have the good HLA identical donors, there may be complications related to bone marrow transplant. And therefore, the cure with bone marrow transplant has mostly to be considered if you have a symptomatic disease. If you have no pain, no problem, the bone marrow transplant is really less needed. And after, there are a lot of hopes with gene therapy, but we need to wait still for some time.
Thank you very much, Doctor. I have another question for you here, Miriam. This is a practical question just about your experience. When you have a pain crisis and you go to the facilities, you've said you've not, fortunately, not had to go to the emergency room, but they're asking specifically, if you're taken to an emergency room, in your experience, do the hospitals treat you as a priority or do you have to wait?
That is a very good question. For a long time, no, they don't treat you as a priority. The first thing was again that I am white and SCD is a black disease, so that was the first thing. Then I was exaggerating. Then there is also the traditional thing with the SCD patients that we are asking for painkillers, and is our pain really as bad as we say it is, because there is no real proof of that. Fortunately, the situation is better. I notice a big difference from when I was a child and a teenager and then an adult, and then more recently. When I joined about 1990 something, I changed hospitals in Lisbon where I lived, and I moved to a oncology hospital in the hematology service. The difference was major, because the first thing that they addressed always was the pain. And then after the pain was down, they would start taking care of the rest. And that's where they taught me that you really need to insist that pain is the first thing to address and then the rest. But that was an oncology hospital with a very good knowledge of pain management. And I'm still followed up with them, so it's very fortunate. But I know that that's not what happens everywhere. So you just need to, the more you know about the disease, the more you know about yourself, and the more you can actually speak, because sometimes it's not easy if you're in a painful crisis to speak or have someone with you to explain that you're not really making it up, and the pain is really, you need to get it down. So one other thing that is also important is, if you work with your hematologist, to have an analgesia plan for day to day and for emergency, because many times you start with a smaller painful episode at home, and if you have the medication and you need what you can do, you know what you can do in those first initial hours, and then you monitor if it's increasing or if it stabilizes or it goes down. It helps a lot. And then when you go to the hospital, you already say that, okay, this is what I have been doing. It started a few hours ago. I took this and this and that because I have this plan with my hematologist, and then it goes from there. And usually when they know that you're not a newbie, so you know you are experienced, unfortunately, in that, it helps a lot.
Unfortunately, I guess that's the one good side of having the experience. We're having a lot of people ask questions about the common thread between sickle cell and diabetes as both chronic conditions. There's a question here from Jacqueline Bowman. Given that sickle cell trait can make chronic complications more severe like diabetes, is this taken into account within the research and clinical community? Dr. Montelambert, just from your perspective, is this generally known among the community at large?
In fact, there are a lot of things which have been evoked about the sickle cell trait. You are talking about the trait.
The question is just, it can impact chronic conditions. It can make other chronic conditions worse, such as diabetes.
No, but the sickle cell disease or the trait? I don't understand the question.
Well, let's just say the sickle cell disease. Let's just leave it at that.
Of course. There is, yes, it's sure that if you have a comorbidity, it will worsen sickle cell disease. It's sure. But diabetes is not frequent in sickle cell. It is not more frequent in sickle cell disease than in other conditions. Sickle cell disease patients do not experience more diabetes than people non-affected with sickle cell disease. So it's not a good thing to have comorbidities, but it is not a special risk. Well, how to say that? There are no more diabetes in sickle cell disease.
Okay, thank you. I have another question here regarding management of the disease. Is there a management app that's available in different countries, or is the only thing available in the English version? I suppose I'll start with you, Miriam. Is there a disease management app?
So I don't use it myself, but I follow several associations throughout the world. And I know that there is one, I think, called Repacare, probably, maybe Yolande knows a little bit about that as well, which is French, and another one which is from the US, which is very recent, but I don't remember the name. But I'm afraid they are not available in all the languages, probably in English or in French, yes.
And Yolanda, any comment on that app?
Yes, so there is a French app which has been developed by patients, which is called Repacare. You were right, Miriam. And this app is not really to manage the disease by itself, but to monitor what is happening in your daily life with the disease. So you can, let's say, put in the app if you are in pain, or if you had a crisis, or if you had an hospital appointment. I think that there are as well reminders accordingly to let's say hygiene of life. So sickle cell disease patients, they have to drink a lot during the day, and they have to monitor other parameters. So this is an educational tool.
Simone, I'd like to come to you. If patients wanted to come together and work with Novartis, what would be the process to do that for sickle cell disease?
I think we are already doing it in a way. I think Dr. Montalembert, within the European in the ERN Euroblood net, there are already EPAGs, European Patient Action Groups. Novartis collaborates with most, if not all, of these groups through dedicated staff. So from that side, from that point, we are already collaborating and providing a number of training tools to evidence-based possibilities to help them do their best job within the European reference networks. We are facilitating their communication, they're facilitating their coordination with our events, plus the general training that we do through our summer school, well, now called Open Academy, composed of a winter, summer, and digital schools. So that's where we cooperate. But specifically, I would say that we start with the European reference network and the EPACs there. There we have common objectives to achieve, particularly with the European reference networks moving potentially into a next phase, certainly in the phase of evaluation. But then when I was looking at the common requests that Dr. Montalembert share earlier in the presentation, many of them, including registries, clinical research networks, are common. And if we work together on those, on creating those infrastructure, then it will be best not only for sickle cell diseases, but also for all the other rare diseases.
Miriam, you have a comment.
Yes, I was looking in my mobile here for the apps. So as in most things on the web, you need to know English basically to move around. And I looked for mobile apps for sickle cell, and there are quite a few. But please try to, so you can investigate this quite easily, but try to go for the web pages that belong to sickle cell associations rather than just generic ones, because there are quite a lot, but you want the ones which are specifically for sickle cell. But as Yolanda said, I don't think there is one that controls everything. There are a number of apps depending on what you want to do, but you have to research it and find. I don't use it, so I keep my spreadsheet. I have a good memory, but it is a good way to start because you really need some help to get everything.
Yolanda, you have a comment, please.
Yes, so with regard to the app, I was willing to add that as we are investigating and getting involved more and more with the sickle cell disease community, we found out that it was a real need for the patient to be able to monitor their symptom and to report their symptom when they are in the appointment with their treating physician, and as well to have access to peers that experience the same challenges that they are experiencing. So we have been launching a mobile app, which is called Sickle Cell Disease Companion App. Unfortunately, it's not yet available in Europe. It will be very soon available in the coming months. But so far, the app has been launched in the US, in Middle East, in Brazil, and so far we have been receiving a good feedback from the patients.
Thank you very much, Yolanda. We still have many, many more questions. Unfortunately, ladies and gentlemen, we're running out of time, which shows you the vitality around this issue. And again, we're extremely grateful for your participation. I do have one final question I would like to ask each member of the panel to contribute. Starting with you, Dr. Montalembert, if you could make one change today to improve access and treatment for rare disease people, those under sickle cell disease, what change would you recommend?
I think I would increase physicians' knowledge about the disease because it is very well known in some countries and very poorly known in some others.
Thank you very much, Dr. Montalembert. Simone, the same question to you, sir. I mean, if you could make one change today, one recommendation to the European Commission, the health mandate is currently under review. What would you do?
I think, can I make two?
I'll give you two, Simone. I will. Yes.
Okay.
As long as you're brief, sir. Yes.
Yes, I'm brief. One is invest in integrating the European reference networks at national level to make sure that referrals are done quickly, much more quickly. And secondly, coordinate and ensure the coordination between member states on accessibility to existing and available therapies.
Thank you very much, Simone. Yolanda, from your perspective, what change should we be making?
For me, this will be to increase awareness, because from this lack of awareness, we saw that all the problems are coming around the disease. And I can only imagine a patient with a rare disease, which is actually not known, and to have this daily challenge, physical, emotional challenge, and amongst that, the lack of awareness from the lay public, but also from the healthcare professionals. So that will be what I will improve for the sickle cell disease patients.
Thank you very much, Yolanda. And certainly the last but not the least word, Miriam, from the patient perspective, what would you like to see done?
I think that it is very important to have in all the countries, starting with European countries, with a bilingual healthcare passport, that it's so in English and then in your own language, that carries the baseline values, the analgesia plan for emergency and on day-to-day basis, your medical history in a summary version, and issues the medication list and the emergency contacts, both personal and medical, because this is something that you could carry around with you at all times. And every time you need, even for just how do you say, for any consultation, or if you travel, or if you move to a different country, as long as it is updated, that's the most powerful tool that you have, is information, and your information.
Thank you very much, Miriam. And again, on behalf of the panel, Dr. Montalembert, Simone, Yolanda, thank you very much for your participation. It's been an amazing, fast hour. And again, there were over 200 of you on the webinar. Thank you for your participation. And with that, I call this webinar to a close. Thank you very much, and see you on the next webinar. Bye-bye.